Good evening, everyone, and welcome to the 23rd monthly webinar series with Dr. Imran Lasker. Again, this evening, he will be going through some plain film and CT cases. We have these cases in a collection for you on the Collective Minds website. You should now all have accounts to that. If you don't, and if you have any trouble accessing the cases, please do drop me a little ping on the chat box below, or you can email help@cmrad.com and someone will be able to help you. So I've just sent that collection through to you now. So please feel free to go through cases whilst Imran is teaching case by case. And please feel free to use the chat to ask him any questions. And there'll be a few poll questions as we go through the cases too. There will be a short feedback at the end of the webinar. Please do fill that in. And then only once we've received your results from that will we be able to send you out a CPD certificate. And yeah, well, I'll hand you over to Imran.
So hi everyone. Got a few people from all over the place today. It's really nice. Thank you so much for joining us. And as always, we are going to be going through some interesting cases. And yeah, we've done a few of these, haven't we? 23. You kind of forget sometimes that's how long we've been doing it for. So it's been yeah, we've done fantastically well from Collector Minds and the support. And as always, I really do hope that you guys get some benefit from this. So just to make sure, I hope everyone's got the link to the cases, and I'm going to start going through some of the cases as well. You know what? I haven't been to some of these places. Holland, I haven't been to yet. Azerbaijan, never been to. This is really amazing. So thank you so much for being part of this and giving us so much of your support. So we've got the cases open up. Let me just make sure I've got them. So hang on. I did have them open. I'm going to click on that link there. So Control C. Sorry about this. I did have it open, but it's gone now. So I'm going to open up again and pull it across. Okay, so hopefully everyone can see my screen, and this is going to be case number one. As always, do feel free to ask whatever you want, and sometimes I get it wrong. It's actually very useful for me to learn from you guys as well. So just let me know what you guys think. We try and keep a breadth of things, so we'll try and make sure that we have kind of fairly easy things, some challenging things, and just things that I found quite interesting that hopefully you guys will find interesting too. So what we'll do now is open this very first case, and there's a poll with this one. So hopefully, Danj can send that poll out while we have a look and try and figure out what's going on. So it looks like we have a single view of a shoulder. Now, a few things that are just worth looking at here is the first off, you want to download the images, and don't worry, it won't get downloaded onto your computer. It'll just be like temporarily downloaded onto your browser. So when you delete it, don't worry, you're not going to lose a whole lot of memory. And I use it most of the time to try and make sure that things are as smooth as possible when I'm doing my presentations. Now, something that's recently come up on Collector Minds is that they've actually got these things called fading arrows. So it's quite good because you can actually like kind of draw away and then draw, and then it will just disappear as time goes on. So something to really play around if you decide to do your own teaching. So let's have a look at this X-ray. So first off, we only actually have one view, and actually having one view is very, very unhelpful because you can't really be 100% of whether this shoulder's going forwards or backwards, right? But we can kind of try and utilize a few ideas to try and make sure to find out whether this person's actually got an anterior posterior dislocation. Now, first off, you can see that there is this sort of Y view almost. Can you see that, right? And what you want to see is that this head of humerus is overlapping that middle of the Y. So that kind of tells you that most likely this is not going to be a dislocation. So let's see. A few people have said that they're thinking anterior dislocation, posterior dislocation, humeral fracture, and a clavicle fracture. Okay, good. So there's some interesting answers here. Now, with the I can see why people would say probably a posterior fracture, right? They're probably thinking because um, it looks like a bit of a light bulb, doesn't it? Oh, hang on, I don't know why that keeps popping up. So it looks like a bit of a light bulb. It's kind of doing this, right? But then the other thing you have to realize as well that we don't have an on-fast view. We don't have a AP view. So it's not going to be entirely accurate. And therefore, I would actually refrain from saying whether there's any dislocation whatsoever, unless you've got at least, two views minimum. I mean, two views at least would be great. Otherwise, I'd be kind of refraining from doing so. But I would say that based on this image alone, the fact that there's some overlap between the glenoid and the head of humerus, I wouldn't say there's a dislocation because anterior would go that way, posterior would go that way. And this looks like it's kind of slap bang in the middle right there. Fine. So I'm not saying, I don't think this is going to be a dislocation. It looks like everything's nicely aligned. One of the kind of check areas I always do is make sure that I've drawn all the way around the scapula to make sure there's no fracture there. Those things can be often missed. And then we have to look at the humerus as well. So a few people thought there was a humeral fracture. So we're going to zoom in a bit and try and take a look. And yeah, there's going to be a bit of overlap of the head of humerus, but actually everything looks very, very nice and smooth all the way along. There's no kind of fracture that I can see or see that I can say that I can see there. So then we're kind of sitting there thinking, okay, well, there must be a reason why I brought it up here today. And the next thing to do is try and have a look at the ribs and make sure there's no evidence of any pneumothorax, right? And that's when you get these lung markings that don't go all the way to the edges. And you can get a bit duped by the very, very top here. And so the next thing you want to do is sort of just zoom in a bit, zoom in a bit, zoom in a bit, and then just pan across. Oops, sorry. And then pan across here and just have a look. And actually, yeah, you can see lung markings going all the way along. So that actually looks okay as well. So still not really finding any gross abnormalities anywhere else, but this person has communal shoulder pain post-injury. So ribs, you've got your posterior ribs going this way, and then as you come down here, it's going to be a lateral ribs, and going all the way down here, you're going to have your anterior ribs. And you keep going down, keep going down, keep going down, and actually there's no evidence of any cortical discrepancy anywhere. The reason why I thought this was an interesting X-ray is because there is something not quite right around here. So you kind of go along this way, keep drawing, keep drawing, keep drawing. And it does feel like the clavicle takes a little bit of a bend this way and then carries on that way. So what we need to do is zoom in a bit more and then see what's going on. Like, why is that not aligned? So things should be fairly smooth inside the human body. But this, again, if you look closely, it kind of does this little dip like this and carries on. So let's zoom in a bit more. And now hopefully you can see that there is a line going like this, and there is like a line doing this and going like this, and you can't really explain it as lung markings, you can't explain it as anything else. And because you've got the angulation as well, that does look like there is a fracture of the mid clavicle. And as I kind of draw your attention to it, you start to see that, yeah, this doesn't look quite right. That does look like there is a fracture. Now, generally speaking, when you do have traumatic injuries, it's going to be the middle third of the clavicle that gets fractured. Generally, the sort of more medial aspect doesn't get fractured. Not the lateral aspect can get fractured, but not as often as the middle third, because that's probably more likely where you're going to get a full-on injury. Interesting, actually, recently I was doing lunges, which is an exercise in case people don't know, and I put my arm across, and I actually ended up having like a ganglion on my sternoclavicular joint, which is gone now, so everyone, it's all good. But yeah, it's kind of harder to really injure your kind of medial aspect because it's such a strong joint. And I guess I must be getting older. I don't know why that happened in the first place, but normally it's going to be quite a significant trauma that would end up affecting the medial clavicle area or something underlying like rheumatoid arthritis and that kind of thing, which did cross my mind. But thankfully, the rest of my joints are okay. So I'm just going to pretend it never happened and hopefully it never happens again. And I'm going to be a little bit more careful when I do my exercising. Right, so let's have a look at this X-ray. So I wanted to have a look at the foot X-ray to begin with. So let's have a look at this one. And this one we can see is a foot X-ray. And the things that I always say to do, and for those that do come to my webinars a lot, is always try and look at the shafts of the metatarsals first and make sure they look very, very smooth all the way along, all the way along, all the way along, all the way along, and make sure there's no evidence of any periosteal reaction. It doesn't look fuzzy or anything like that, because so often stress fractures can be missed. And so we're doing a good job. We haven't seen anything looking like a stress fracture. Then we look at the metatarsal heads and just make sure they look very, very nice and well corticated and not too sclerotic. And when I say sclerotic, I mean they don't look like they got increased whiteness or maybe even loss of some of the normal contour. So it looks very smooth right now, but if it starts to look a bit irregular or maybe a bit denser in that area, then you may be worried that there could be some sort of vascular necrosis, something called Freeberg's infraction. But here we don't see anything like that. And the next thing I always try and do is try and look for the things that you wouldn't usually have problems with. And it's going to be that terminal phalanges, right? And so this is kind of an unusual place, but you can get fractures. Very, very important to keep drawing around every single line. And I've said this before, always check the nail bed and make sure you're not confusing a nail bed with a fracture. So again, you may say, oh, I think there's a fracture here, but actually there's some soft tissue over here going across like this, giving you a lot of composite shadow. Again, they're going along like this. There's no fracture there. These are all soft tissue, so the actual soft tissue of the toes themselves. So again, I don't think I can see any fractures of the terminal phalanges at all. Now you have to look at the alignment. Okay, so this may be a little bit difficult because you can't see quite so well the alignment of the second base of the second metatarsal with that middle cuneiform. But the rest of the metatarsals look like they align quite nicely. Nothing looks like it's moved across. So at the moment, anyway, we can say that I don't think we can see or say that there is what looks like a fracture, a ligament injury. So you have a Lisfranc ligament that kind of holds things in place. And if that gets torn, then you get everything sort of moving across and ending up causing a whole lot of issues. Sometimes you get navicular fractures, but this one looks very nice. Doesn't look like there's any fracture there. Now, often fractures over here get missed, and it's actually fairly common, right? And I think it's a lot to do with the way the angle, when the foot bends or inverts itself, a lot of pressure must end up in this particular area over here, right down this area. And so often you may not see a fracture until you get a CT scan. There'll be like a little tiny fracture there. So those of you that do end up having a CT scan or getting a CT scan asked for in a patient with continued foot pain after injury, try and have a look in this area because more often than not, that is an area where I see a fair few injuries, and it's like a bit of a pattern now that I've seen over time. Right, so I don't know why that's come up, but let's get rid of that happy face. So then what we need to do is have a look at the rest of this X-ray. And the reason I brought it up is because sometimes you may see a calcaneal fracture, but when you come all the way around here, can you see there's that sort of lateral malleolus, and then that becomes out of line over there. And the lateral malleolus looks out of line there as well. So there looks like actually there could be a fracture located within that region of the lateral malleolus or the distal fibula. But having a further look, you can see that actually that posterior cortex, that kind of area over here, which is the posterior aspect of the tibia, also looks a bit abnormal. So let's zoom in a bit and have a look. Maybe I need to sort of window a bit, just try and convince you guys. But that should be quite smooth. But then here it looks very irregular and very abnormal, like it looks a bit crumpled actually. And thankfully, we do have another view, which is the lateral view, which gives us a really good way to see what's actually happening here. So you can see actually here, it looks like the posterior tibial plafond looks like there's a fracture. You've also got this lateral malleolus or lateral distal aspect of fibula that is kind of fractured as well. This is also a good opportunity to try and have a look at the cortex. And I always say, look, have a look at that lines, have a look at the cortical lines, have a look at the cortical lines, and make sure that you've had a good look around there because you want to make sure there's no evidence of any you can get some of stress fractures. So if there's a line that kind of goes in a different angle to everything else, then you've got to be worried about stress fracture. But we don't have that here. What we look like we have is a definite sort of lateral malleolar fracture and a posterior malleolar fracture as well. Now, it's quite unusual. I mean, a lot of the time you've got to be careful there's not another fracture, the medial malleolus, because then you'd have like a trimalleolar fracture. So you just want to make sure that you have a good look in here and just make sure that medial malleolus looks okay. Now, a word to word to you guys, just to be sure that you know, is that when you look at the soft tissues of most people anyway, you'll see that the skin goes right over very close to the lateral malleolus and very close to the medial malleolus. So especially in someone who's younger, if you've got this extensive soft tissue swelling like this and like this over both sides, then I'd be very careful and I'd have a very good look and make sure there's no evidence of any fracture. And they may be sitting there with a ligamentous injury, and all you're seeing is the soft tissue swelling around. So just have a good look because sometimes the soft tissue can be kind of a light bulb moment, like, okay, there's something very abnormal here. Final thing is also to have a look at that talar dome because you can often see that there is a osteochondral defect, and usually will be in the supremedial aspect because usually the weight of the body goes down the medial aspect of the body. Okay, so this one's got, and actually you can actually see a bit of the fracture on this side. So let's get rid of that. You can see a bit of the fracture on this side, but it's not as obvious as when you see it on the lateral views as well. Right, so let's go on to, oh yeah, greetings to Mexico. Hey, I don't think I've seen you in a while. Hope you've been all right. Okay, so let's have a look. What is the final diagnosis of the foot? Okay, so I said that final diagnosis of the foot was going to be a lateral malleolar fracture and a posterior tibial plafond fracture, a posterior malleolar fracture. The actual foot is okay, so it's the ankle that's the main issue, and I was trying to highlight that. Sometimes you get people coming with foot pain, and you have a look at the ankle, and that's the actual abnormality rather than the foot. And you don't blame people, they come in and they've got pain, they don't know, and it's all swollen up and painful. It's very difficult. So I don't blame them for having not being able to really identify where it is. Hate to grease as well. Okay, so let's have a look at this one. So unfortunately, I did try and get better images, but I ended up having to take a screen cap. So what I'll have a look is we've got kind of three views of the wrist, right? And one of the things you'd want to do is just make sure that the scaphoid looks okay, and also look at the scapholunate distance, make sure there's no fracture there or widening of the scapholunate Shoulder dislocation. I think you might be on a different case. No, we're doing the wrist now. So then we have a look at the radius and make sure there's no evidence of any fracture. Then actually that looks very, very smooth. And on the styloid is also somewhere that looks very, very smooth as well. So at the moment we don't see anything grossly abnormal. Sometimes you want to make sure that these areas look okay. You get a lot of STT. So, you get some osteoarthritis over here, you get osteoarthritis over here because most of us are on our thumbs like this the whole time, looking at our phones and all that kind of thing. But actually, these look okay, and you can actually see that this is very, very smooth. So quite a youngish patient. So we're not expecting to see calcified vascular channels, anything like that. They look fairly young. Actually, when you zoom in now, yeah, people have said it. You got a little bit of a nub in there. You kind of carry on down, and actually, you can see the kind of radiolucent line going all the way like this, and this radiolucent lines again repeated over here as well. You can't see it so well there. It'll be hard to see it there, but there definitely, and there definitely. So how do I know it's not a vascular channel? Like, how do you know? So the thing to do is to really have a close look, and I know it's not projecting particularly well, but if it looks very, very sclerotic or very, very white, like this, all the way up to the edges, then you're probably looking at vascular channel. But this kind of goes at the wrong orientation to be a vascular channel. Vascular channels normally be kind of doing this, like this, but this goes kind of a different orientation, and it's very, very loose, radial loose with no sclerosis adjacent to it at all. So yeah, this is going to be a distal radial fracture with no evidence of impaction, and as far as we can tell in this image, no articular surface involvement as well, and no other involvement of any other parts of the hand or wrist. Right, so we have been through a few X-rays. Actually, there's another X-ray here. Let's go for this one. So no questions about that one. Okay, so this one, let's have a look. I'm going to slow down a bit. I want you guys to start having a look and tell me what you guys think. Okay, so one of the clues, yeah, fair enough. Like it does say red dot, so yeah, well done. Um, and we can see that we've got an adult patient. It looks like we have got, um, I mean, I don't see much in the way of arthritis. One of the things that you can say is that that femoral head looks a little bit kind of large like this and goes over. So there is a bit of what we call a cam deformity. Femoral head should really kind of do, like not, I mean, I've exaggerated it, but should really kind of scoot down like this. But when you've got this kind of more obtuse angle, it means that this area here can hit that area there. And sometimes you can get some sort of accelerated degenerative changes. So you may have a bit of sclerosis there and a bit of sclerosis there. So please decrease factors. Well, do you mean the windowing? Maybe that's what you mean. Is that what you mean? Okay, so I'll window it down a bit just so that it helps in case. But you can say, yeah, okay, there's a bit of a cam deformity. I can't see any evidence of any degenerative changes anywhere at all on this. And then one of the places you also want to look is have a look. You know how I was showing you the trabecular pattern of the calcaneum? You want to do exactly the same with the femur. You want to have a good look at the femur, make sure that there's no evidence of any loss of that normal cortical pattern. Because if you see like a line going like this, then you're probably thinking about an impacted fracture. And they can be pretty subtle, actually, subtle. So just be sure you've had a good look, right? So you haven't seen any fractures there. Sometimes you get an avulsion injury of the anterior inferior iliac spine, and that's where you get your rectus femoris muscle. And you can sometimes have an avulsion here as well, which can be anterior superior iliac spine. And so that would normally happen in younger patients because the attachments of the tendons are stronger than the actual bone itself, and they can fall off. But this is an adult patient. We can tell that there's no growth plates and there's no evidence of any fractures anywhere along the body. And also just make sure you have a look at the trabecular pattern as well. Sometimes you may spot a destructive bone lesion, but this all looks okay. Right. Sacroiliac joints, they look okay. Not an ideal for the ideal view for the sacroiliac joints, but also it's still quite important to have a good look and make sure there's nothing abnormal. Now we can draw it along the inner brim like this of the pelvis like so, and make sure everything nicely aligns like this, all the way around like that, and do the same thing on this side and make sure it all kind of goes around like that. And at this point, you may be thinking there's not really much going on. Let's go this side, draw all the way around like this, all the way around like this, and all the way around like this, all the way like this. And you start to say, yeah, you know what? There is something going on here. Can you see that? It looks like a bony shard has just sort of fallen off like this way. But then the actual femur looks okay, actually, doesn't it? Considering that looks like it could be a pelvic brim fracture. So this is quite a serious looking injury. What we need to do is zoom in the back, and sometimes you may be able to spot like a fracture line going around the back here. I can't say I convincingly see one. Maybe there's a line like this, but yeah, 100%. Yeah, that doesn't look quite normal as well. Also, don't get put off by these little tiny calcifications. They're phleboliths, so they're not really anything to worry about. So yeah, this patient did end up going to get a CT scan, and I think you can pretty much see straight away that there's something very, very abnormal. But let's go from the top all the way down, all the way down, all the way down like so. And yeah, you can see that looks like an anterior column and a posterior column fracture there. This fracture goes all the way down to the anterior aspect over here as well. It's got quite a community. There's a loads of fracture lines going this way, loads of these fractures going all the way down like so, all the way along. And actually, this fracture seems to go superiorly along the iliac blade. You can see that all the way that way and all the way along that way, and almost goes towards the sacroiliac joint, but doesn't quite reach there. The thing I'd say is always have a look at the sacroiliac joints just to be sure that there's no significant widening, because if you get widened, there could be some disruption there. But the sacroiliac joints actually doesn't look like it's widened, and I don't think I can convincingly say there's any involvement of any fracture there, which is good, I guess, for this patient, amongst the bad news that they've got a really, really significant and bad fracture. Now let's have a look at the rest of the body, because you have to be careful, right? Because if you look at the fat planes here, can you see the fat plane there? Compare that to the fat plane there. So there's a lot of edema because obviously they've hurt themselves quite badly. Let's have a look at the rest of the body, and then you just want to have a look and see what's going on. So you can actually see that kind of stuff sitting there. Can you see that? Let's make sure. Yeah, can you see? If you keep your eyes around this area and we scroll down, keep scrolling, you can see the sort of strandy stuff sitting around here. Keep coming down, coming down. I'm going up, aren't I? Let's go down, 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 down. So yeah, they look like they've got quite a significant injury, and they've actually got a bit of a hematoma sitting within the sort of inner brim of the pelvic brim, and you can see some more hematoma there compared to that hematoma. And the reason why I think it is quite important, just to make sure you've had a look at everything else, fractures can be really significant, especially in significant trauma. You just want to make sure there's no bladder injury. Would be difficult to tell in this particular situation, but you may end up having to put contrast in and trying to see whether the contrast is spilling into the pelvis or out of the pelvis, because then that would mean that this person's either got a bladder injury that's intraperitoneal versus extraperitoneal, and then that can actually decipher what kind of treatment they have. So this one doesn't look like they've got any sort of bladder injury from what we can see, but we can say that there is definitely a hematoma along the interior brim of the right pelvis. We don't have contrast, so we can't say where this is actively bleeding. There's definitely one there, and just maybe something to be considering as someone moves on. If they start to lose their HB, then they may need to do a contrast scan to try and see whether the person is still bleeding. Okay, so let's have a look at this case. We'll start with the X-ray, because that's always a fun thing to do. So we have got an adult patient, and so it looks like they haven't breathed in very well, have they? They have kind of not breathed in great, or maybe they don't have very well inflated lungs. Maybe they can't inflate their lungs. Across the angles, they look pretty sharp. EPC's got to make sure there's no pneumothorax. So no pneumothorax. They all look very, very clear, which is good. Mediastinum is an AP view, so you got to kind of take that with a bit of a pinch of salt. That the mediastinum might look slightly enlarged, but actually, as you kind of zoom in a bit, you start to feel as actually things look a bit reticular. And so reticular is a phrase that you use for if it looks a bit netted. And netting means like a fishing net, I guess. So you can see kind of linear lines going all the way to the edges. Now, things should end up kind of going all the way along, as you kind of go towards the corners or to the edges, the little kind of line should become less and like basically get smaller and smaller. But these ones, yeah, they look like interstitial markings all the way along, right? And then if we kind of go around the rest of the body and just have a good look around, it does look like there are sort of linear reticular lines going all the way to the edges, all over the place. So it is actually looking very, very busy. Now, in terms of cystic change, I think it's going to be difficult to say that there's any cystic change on this. But in the context of someone being particularly breathless, and if they're coming in, maybe they've come in a few times saying that they're breathless, they end up getting a CT scan, and the CT scan is what we're going to be looking at now. Now, again, for those that don't know, Collective Minds is really pretty impressive because you can just press the numbers and get your windows, and it's pretty much like working at home on your station. And now what you can see is that, when the lungs look a little bit like seagulls, it's kind of little seagull signs rather than look like nets, it means they breathe a bit. So there is there's a bit of breathing artifact. But as you kind of scroll through, you can start to see that, yeah, you know what, it's starting to look very, very busy. They have breathed, but there's kind of this linear lines all over the place. Coming further down, it looks like more breathing line, more breathing, more breathing, more breathing everywhere. But as you come further down to the more inferior aspects of the lungs, you can see that, yeah, you know what? There are some areas that look a bit spherical. Can you see that? They look like radiolucent spheric areas. Let's just do. Can I zoom in like this? Yeah, I can. They look like little circles just along the edges, right? And so these are what look like subpleural cystic changes. But then as we scroll further down, you can see that the airways themselves, so airways shouldn't, I mean, the airway should kind of get thinner as you go more towards the edges. But look at that airway there. It kind of continues to be big and continues to be big. And so that's basically what is known as bronchiectasis. Now you get two different kinds, or I mean, you may have a few, but bronchiectasis can be pretty much split into traction bronchiectasis versus sort of inflammatory, or sort of yeah, you can get sort of a more cylindrical bronchiectasis. Cylindrical bronchiectasis look like a circle. They look fat, but look like a circle, like a tube. But this one looks like it's kind of a bit irregular, right? So I could pretty much draw it like this if you're going to be pretty like a bit exaggerated about it, and that's because it's kind of traction. So what's happening is that the airway is being pulled apart. They're getting wider because there's been loss of lung volume from everywhere else. So things are kind of pulled away from one another, and the lungs look like they're shrinking in truth. Now, the inferior aspects are a bit difficult to see because, yeah, I mean, there is a lot of breathing artifact, but again, you can see a fair bit of subpleural cystic change, a bit more prominent cystic change in both lower lobes. There is a bit of what looks like consolidative change. So I was talking about cystic traction bronchiectasis. But can you see here, these areas look like they're slightly dilated, but they look like they are thickened. So there's actually a bit of thickened as well, a thickened bit of airway as well. So there could be a combination of inflammation on a background of interstitial lung disease. So a few people said already that this is going to be more in keeping with underlying interstitial lung disease. And with a lower lobe predominance and a subpleural predominance, then you're probably looking at something like UIP pattern. So it's a pattern which has got a few different reasons for it. Now, the reasons why I wouldn't say it's tuberculosis, I mean, there's a few differentials for UIP, but the reason why I wouldn't say it's tuberculosis, generally speaking, with tuberculosis, you'd have upper lobe involvement. You may have some calcified lymph nodes. You may have some cavities. This one, I don't think you've got any of those things, but what you do have, it looks like they've got interstitial lung disease with a concurrent like areas of consolidation and mucus plugging. For those that aren't convinced about the mucus plugging, look at the airway there and look just beyond it. It looks like it's kind of disappeared. It becomes a bit fat and lost. Coming back up, it becomes a bit airway-like, and then you can't see it so well. And there's some more confluent areas of consolidation that are located here and here as well. I mean, you know what? I better just make sure that just in case you guys don't make the same mistake I did once a while ago. I said everything was normal. I think I brought it to one of our cases actually, and actually the very, very top of one of the kidneys ended up having a lesion. These things happen, but it's very, very important that you do have a look at the upper abdominal solid organs on the off chance there's something there. And there's been occasional, there's also been pancreatitis and a big collection. So very, very important they have a look at the upper abdominal images as well, because I mean, I guess being a radiologist, that's what people would expect me to do, to have a look at absolutely everything, which will become apparent as we go through the rest of this talk. So let's start with the chest CT on this one. The chest CT is this one, and this was a young patient. Was it? Yeah. So they were a young patient and they had raised white cell count. They're under hematology, and hematology were worried. I think if this is the one, they were worried that they could have underlying lymphoma, and they did a CT scan, if I remember correctly. Let's have a look. I might be wrong, but I think this is the case. They were young. And I guess we just start from the very top and just make sure that we haven't seen anything grossly abnormal anywhere. And actually, at the moment, doesn't look like we have any enlarged lymph nodes anywhere. So I think we're okay on that side of things. So no enlarged lymph nodes. Let's go to the lung windows and see what they look like. So again, you know, they look like little seagulls here, like here and here. They don't look like they connect like you'd expect with lung parenchyma. So they've obviously breathed a fair bit. And just scrolling through, you can't see anything grossly abnormal. And especially around the lung base, it can be very difficult to tell what's going on because they breathe so much. Can be useful to try and do these MIP images. Let's just go to layout one, and then MIPs can be very, very good. So you can do this and try and look at what the lungs look like. And you can see how it looks like a bit of a tree. But as you kind of come to the bottom, it can be difficult. When they breathe so much, it can be difficult to be 100% there's no lesions there. But from the initial inspection, it doesn't look like there's any lung lesions anywhere on this person. So that's good news as well. Right. So let's go back to that CT chest. So at the moment, we haven't seen anything grossly abnormal with regards to the CT chest. No lymphadenopathy, no pneumothorax, no interstitial lung disease, no subpleural disease or anything like that. So everything looks like things are going well. We're happy. But then remember what I said. You've got to make sure, I mean, everyone right now is radiologists, have a look at the upper abdominal solid organs as well. So spleen doesn't look particularly big. They were worried that this person could have underlying lymphoma, but I haven't seen anything grossly abnormal, and there's no enlarged lymph nodes anywhere within these regions here. The pancreas looks okay, and the kidney and the liver looks okay. So we could go away thinking everything's fine, but actually, if we go to the lung windows, which I've forgotten which the one they are, four, number four, you kind of scroll up, scroll up. I don't know if anyone can see that. Did anyone see that? Come back up. Okay, I'll do it slowly again, if any in case anyone hasn't seen it. So you know where the diaphragm is. So if we come up to, let's say, this point, we're going down or up, down or up. There. So you know the diaphragm is this, right? So therefore, any lung should be anterior above, but this bit of air looks like it's underneath. So there looks like there's air under the hemidiaphragm on the right side. I wonder if we can see any more anywhere else, right at the very top. Yeah. So if you come up to here, you can see lung, diaphragm, air. So they've clearly perforated something. Something's happened, right? So therefore, you need to do a CT scan of the abdomen and pelvis and see what's going on. Right. So what could perf? I mean, yeah, you could have a perforated gallbladder, but you don't usually get air with that. Gallbladder looks okay. The kidneys look okay on the first instance, and the spleen, yeah, that doesn't look like it's particularly big. I mean, yeah, actually it does. No, it looks okay. I wouldn't be too worried about it. I'm worried about the perforation. Something's happened. So pancreas looks okay. So the next thing we need to do is go right from the very, very bottom and scroll our way up, up, up. So this is where we are. Scroll, 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 scroll. We're going this way. Let me get my mouse out actually. We are three. No, yes, we are. So scrolling this way, scrolling this way, scrolling this way. Look, this way we are. Scroll that way. So if you're ever worried, always go for the constants. Always be the ascending and descending colon, always the constant. So this is the descending colon. We're scrolling up, going backwards, going up, 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 up to the splenic flexure. Where does it go? Where does it go now? Oh, it goes across like this, going across the front, come across the front, come across the front, come across the front, come across the front, and everything looks okay. We're at the hepatic flexure, coming down this way, coming down this way, and it starts to look very, very inflamed around this area. Can you see that? Look at that fat. Look at that fat. That fat looks okay. That fat doesn't look like it's okay. Coming further down, and you start to think that there's something going on here, right? So next thing we need to do is try and identify the ileocecal valve. Now, the ileocecal valve is going to be is like the ileocecal valve has got fat, looks like fat lips. So there's a bit of fat just sitting there. So that's the ileocecal valve, and you can see from there is coming some of that small bowel going this way and this way. But actually, there's another piece of bowel here. Can you see that going that way and upwards, upwards, upwards? Let's see where that goes. All the way up, all the way up, and all the way up. And there you go. So actually, that looks like an acute appendicitis. They've got acute appendicitis. Now, what I didn't tell you actually is that they had this CT first. Right. So if they had this CT first and they had appendicitis, let's have a look at those areas where there was air. There's no air right there, right now. So what actually happened, which I'm still a bit baffled about, is that I mean, I'm sure they had their reasons, but they had the CT outdoor pelvis first, which showed appendicitis. But then a couple of days later, at some point, somewhere along the line, someone felt that they could have an underlying malignancy, such as lymphoma. They did the CT scan. It turned out the appendix that they'd originally found has actually perforated. So they need to do maybe a little bit more than they initially anticipated for this person. But yeah, quite interesting case and quite important to make sure you have a look at the upper abdominal organ as well, just to be sure that even though it's a chest image and all the rest of it, just make sure you've had a good look around. Because yeah, this is where, well, I don't know. I mean, this is where your importance comes into play. Now, this one, let's have a look. So again, similar, this is slightly similar, I guess, in some ways. This person had right iliac fossa pain. So as soon as you start thinking to yourself, okay, Right iliac fossa pain, what could it be? What do we think it is, right? So I'm going to do one scroll through for people that haven't got it on their own screens once it uploads. And you can tell me what you guys think by using the poll and putting down what you think it is, right? So we've got right iliac fossa pain, and have a scroll through first if you can. Otherwise, that's fine. Just take a guess. So yeah, right iliac fossa pain, you'd be thinking, yeah, appendicitis. I mean, that's usually what it's going to be. I mean, you could get, I don't know, ileocecal valve inflammation in Crohn's and Yersinia infections and all that kind of stuff. But right iliac fossa pain would usually be something along the lines of appendicitis. But I always have a system. Whenever I do any sort of CT scan, I try and pretend I don't have a history. Have a look at the gallbladder, make sure it looks okay. Then have a look at the pancreas because that's going to be the thing that causes pain. That looks okay. Have a look at the kidneys. And again, they look okay. They don't look particularly inflamed. So we're not worried about that either. Right. So then we have to go all the way to the very, very end and follow all the way around. So people are saying appendicitis. Some people also got 50-50 on this one. It's awesome. 50-50. Right. So then I'm going to try and get you through the dilemma that I had with this one once we have got all the images uploaded. Right. So good. Well done. So more people going for, so it basically between a pepiploic appendicitis and appendicitis. Okay. We've kind of gone more and more towards epiploic. So let's go for that. Okay. So good. Let's try and see what's going on here. Right. So let's go from the very, very bottom. So yeah, they do have what looks like, that keeps coming up. They do have what looks like, okay, man. Okay, they do have what looks like a that's good. Okay, so yeah, you can see they've got a bit of a hernia there, which contains some fat. Let's have a look at the rectal area. Come up, come up, come up, all the way down like this, coming all the way down like this, coming all the way along like this. So this person came in with pain in the right iliac fossa. Okay, we're going to get to the right iliac fossa in just a minute. Okay, splenic flexure, work our way across, work our way across, all the way across like so, all the way across like so, coming all the way across like this. Now we're at the hepatic flexure, work our way down, work our way down, work our way down. And we haven't seen the appendix. But actually, if you look at that fat over there, that looks very, very different from fat there, fat from everywhere. So that looks very, very different, doesn't it? It looks very, very strandy in that area. This is where we've got to try and use the coronal images and try and see what's happening in this area. So let's go across and try and find this appendix. So that's going to be the ascending colon. You've got the ileocecal valve there, haven't you? That must be the ileocecal valve because you've got your fat lips. Can you see that? And that's where you got the small terminalum coming out. And then can't really see an appendix actually. Normally you could see an appendix quite nicely, but I can't say that I've seen an appendix. But all the inflammation is definitely on that side, and it seems to be far away from any sort of look of inflamed bowel. I mean, if that was the appendix, it doesn't look particularly inflamed, but you do have a fair bit of inflammation located within that region. So a fair few people have said it. You are correct. I think this is probably going to be epiploic appendicitis, which can be, you kind of got these attachments here. They can get inflamed. It can happen because of anything really, but they they can be a bit of red herring because you think it's appendicitis or diverticulitis, and then you don't really treat it per se. You just leave it alone, and eventually will calcify, and it'll be fine. But yeah, you definitely have what looks like epiploic appendicitis sitting there. So we're done and we're thinking we're all good and we're about to go and say, look, everyone, leave the person alone. They don't need anything else. Just they can go home and they'll be fine. But someone said it and well done to you. You have picked it up. But there is something that looks a little bit abnormal sitting within the bladder here. Can you see that? If you kind of look quite closely there, and if we come back to the axial view, so let's go back to the axial views and come to the urinary bladder. There, can you see that? And that's not like an indentation of the prostate. The prostate's here. It's very, very far away. It's a lobulated soft tissue lesion that is sitting on the lateral aspect of the urinary bladder. Definitely not fluid, because fluid looks like this. This looks like soft tissue, looks like slightly enhancing. You'd be very concerned there's actually an incidental finding of an underlying bladder cancer, such as a TCC. This person will need to be followed up. Now, this is quite an important case because, like in radiology anyway, I think regardless of what radiology you end up doing, if it's MSK, if it's chest radiology and all that kind of thing, the one thing that you're not really allowed to miss, and I mean, we shouldn't miss anything really, right? But everyone is looking for cancer on some level. Like you can't go do a meniscal tear and not spot a femoral, a femoral cancer, right? You can't do an MRI of the neck and not spot the apical malignancy. And in fact, today, or was it yesterday, I had a case where someone had a fracture of the humerus, and they actually end up having you had this much of the image, and there was like a spiculated lesion sitting in the apex. And these are the cases that you need to be worried about. Not worried about, but you've got to be careful of because you say leave this person alone and they come back in a year's time and things have got massively worse, like multiple lesions all over the place. So you can potentially really make a difference by having good check areas. And I think, at first glance, you get so focused on something in radiology they call satisfaction of search, right? So satisfaction of search is you're so focused on the abnormality, you're looking, yep, done it, slam dunk, I'm going to go home. And it turns out there was something else going on, which may not be related or related, difficult to tell. But this is, I thought, an important case to bring up to everyone as well. Right. So hopefully that was useful. Yeah, a fair few people got it. So well done. That was not an easy, I don't think it was an easy case. Right. So this person comes in and they have got neck pain, right? And I think ENT get involved and they're saying that they feel as though they need to do a CT neck with contrast because they're worried there could be an underlying collection. So this looks like a CT scan of the neck and looks like we've got some of the base of the skull as well. So you can see there's contrast. So if you look at the vessels, they look like they've got contrast within them. If you're ever unsure, you can also look at the mucosal area as well. If they look slightly enhancing, then yeah, you're probably looking at a contrast enhanced study. You can see the circle of Willis looks okay, so that's good. So the vessels look like they're okay. Yes, it's not a dedicated study, but it's all still very, very important to make sure you have a good look around. So, by the way, I'm not a head and neck radiologist. Like I say, I bring this more for interest and slightly entertaining and hopefully give some learning points. And maybe I can learn from you guys too. When you come from this to down to this area, remember the fat, a lot of the time on CT, fat is your friend. So look at the fat plane there, look at the fat plane there, look at the flat plane there, look at the flat plane there. It doesn't look quite right, does it? Coming further down, this fat in this area doesn't look quite the same as the other side. It looks completely asymmetrical. Looks like there's something else going on around this area, right? So you've got your thyroid gland there. Let's see if we can find any enlarged lymph nodes. No enlarged lymph nodes from what we can see. Okay, that's a carotid vessel. And that kind of goes through this way, goes in, and that doesn't look like it's obstructed or anything. But actually, this whole area doesn't look quite the same as this area. So let's have a look and look at the lung windows. Actually, yeah, so there's a bit of a opacification over here and a bit of opacification over here as well. So that doesn't look quite right, but the bone just seems a little bit sort of fuzzy in this area. So I'd be concerned there could be some inflammation over here. And when you come down to this area, and it's a contrast enhanced study, you can actually see there's a little bit of enhancement around this area. Can you see that? It looks like there could be a small collection that is located within the area over there. So there compared to there, it definitely looks like there's a lot more going on and a sort of a rim enhancing area over here. So you'd be concerned there could be a collection. Maybe it's come from underlying, yeah, exactly, like necrotizing otitis externa. It could be all of those things. But the thing to also notice is that if you look at the venous sinuses, can you see that? That one compared to that one going along, that one compared to that one, it just doesn't look quite right, does it? Going this way, this way, this way. It looks like it's got what looks like a filling defect as well. So what you've got is a filling defect along the transverse sinus, the sigmoid sinus as well, and you've got a significant amount of inflammation located within the mastoid air cells. You've got a bit of mastoiditis, inflammation located within the neck region over there, and what looks like could be a potential collection just adjacent to all of that. So quite important that yeah, like again, this could be another one that's satisfaction of search as we think, okay, I've got it. Inflammation, looks like a small collection, lots of fat planes between the musculature of the base, the posterior neck and all the rest of it. And then kind of forget that actually you've given a contrast study, you probably should look at the vessels as well. And you can see, yeah, there's definitely a filling defect, which is a sinus thrombosis. Cool. Yeah, I mean, most of you guys got that. So yeah, well done. Tonsils, right? Tonsils probably be around here, wouldn't they? Right? So probably not quite related to that. I can't see if there could be a connection between the two. I think a lot of the action is going to be in the mastoid air cells, really, rather than anywhere else. Right, let's have a look at this case. We'll go for the chest X-ray first. And just download this one. Okay, so we are looking at a chest X-ray, and this is of an adult patient. We can see there's an AP view, so you can't really be 100% about how big the heart is, but it doesn't look like it's significantly enlarged, so I think we're okay. Mediastinum looks okay. Hyla look okay as well. So that all looks good. Lung apices, very, very important. Have a look at the lung apices. Make sure, let me just download all this stuff as well. Look at the lung apices. Make sure the lung markings go all the way through to the edges. So lung markings, yeah, I think they are going all the way to the edges. I can't say that I can see any pneumothorax. They don't look particularly radiolucent and compared to the other side. So that's good. Under the hemidiaphragms, I can't say I can see any evidence of any air under the hemidiaphragms, but actually, when you zoom into that costophrenic angle, it does feel like it's a little bit less sharp than the costophrenic angle on this side. Okay, so that's not great. And now when you look at the, yeah, so someone says atelectasis, but then if you look at this area over here, so what I always say is try and draw a square, yeah, and draw a square there. So compare the two sides. And this square just looks a little bit more like hazy. And as you look closer, you can see there's kind of radiolucency linear areas going all the way through it, right? All the way through. This one, not so much, but that looks like there's some radiolucency over this region. Now, the heart border is maintained, right? So we're probably thinking that whatever's going on is not involving the right middle lobe. You're probably more looking at a right lower lobe. So something's going on in that right lower lobe. And because you've got these linear radiolucencies, I'd be concerned there could be a small pleural effusion and actually, I wouldn't say collapse because what you need to do is make sure that you had a look at lung volumes. Now, the hilar look about aligned. There's no tenting of the hemidiaphragm. Doesn't look like there's any crowding of the ribs here. I wouldn't go for a sort of full-on collapse per se. Now let's look at the CT scan. And yeah, now what you can see is, I mean, even if I did one scroll through all the way through like so, you can see that, yeah, this is not like the other scans that we've seen so far. There's a fair bit going on. Right, so let's go to, I think it's number 4, which is going to be the lung windows. And you come to the top and they breathed a bit, haven't they? Again, you kind of got the seagull appearance to the lungs, not that net-like structure that you'd normally get. But as you come further down, you can see there are a few focal areas of this kind of cloudy stuff all over the place, right? Coming further down, you can see there is a pleural effusion like so. Coming further down, and now you can start to see that there is quite extensive amount of what looks like consolidation. Why is it consolidation? Because you can see the airways going all the way through. Like you can see airways going here, and these are called air bronchograms, right? So there's fluid around the airways. Now, I wouldn't say it's collapse per se, because what you've got here is added value rather than loss of value, right? The right middle lobe was maintained, so it wasn't a right middle lobe. It's definitely going to be a right lower lobe, right? Here you actually do have a few areas of consolidated change. So what I'll do, this is what I used to do. I mean, probably a good thing to do is have a look at side by side. And then sometimes on this one, you can go coronal and just try and compare the two. So now we're kind of looking at the X-ray versus the CT scan. And you can see that, yeah, that kind of coincides quite nicely. You can see the air bronchograms are here. You can see fair few air bronchograms here. This is a little bit more difficult, but there is some consolidative changes here. So that's something to sort of take forward, that if it looks a little bit patchy, maybe go for that. But the key thing is here that that right middle lobe actually looks completely normal, doesn't it? And the way I try and remember it, like when I do a fair bit of teaching for medical students and stuff, it can be difficult to try and remember these things. So try and pretend that you try and draw like a little McDonald's M on this side. If you can't see that McDonald's M, then you're looking at right middle lobe consolidation. But because you can see that little M, I've just basically drawn that out of the blue. It's just a way to remember things. But yeah, if you can't see that M, then you are looking at a right lower lobe consolidation, which is actually proven on this particular X-ray. And that blunting of the costophrenic angle would also be in keeping with the underlying pleural effusion that we can see. So final thing is to always make sure you can see if there's any enlarged lymph nodes anywhere, which we can't see. And it's also quite important to make sure that this thing hasn't become some sort of cavitating mass, because sometimes you get such significant consolidative changes. You don't get linear radiolucencies, collections along the stomach on the CT. Okay, I'll have a look in a second. So you get these linear radiolucencies like this, but if it became like a more focal radiolucency, then you may be thinking about, okay, this could be an underlying cavity of some sort. So someone said that there were some unusual linear gas collections along the stomach on the CT. So you can get rugal folds. So, and the stomach is very difficult to assess on CT anyway. So I kind of refrain from it unless it's something grossly abnormal. But you normally get these rugal folds, and sometimes you get air because people are eating, they're drinking. But yeah, you get a little bit of air down here. You got some air going down this way as well. Let's have a look on the coronal view just to make sure there's no evidence of any perforation or anything like that. So let's have a look. That's all your kind of food inside there. none of it's going beyond the actual stomach wall from what we can see. You can see that. So it's all within the stomach, all within the stomach, all within the stomach, all the way along. So you've got esophagus, stomach contents, and a whole load of air. So the I don't know, swallowing some air, going to burp later, who knows? But yeah, I don't think there's anything going wrong with the abdomen there, but it's very good that we do check because obviously we want to make sure we haven't missed anything like with the other scan. But yeah, I don't think on this one we can say that there is underlying perforation, collection, ischemia, or anything like that. This is just a good example of right middle lobe pneumonia. Just out of interest, did anyone spot this? Any ideas what that could be? If we zoom in, that one there. So yeah, I mean, you'd be worried. You may be worried. You know, is that a fracture? Is it not a fracture? You may want to zoom in and all that kind of stuff. Yeah, be very careful. I think I might have said the story a long time ago, but there was like a motorcycle accident and two brothers, one went flipping over and hit his back. And I was very, very junior at the time and I was really worried about this, had to call my consultant in. And yeah, when you've got like a linear line like this where it's very sclerotic to the edges and goes right down to the middle of the vertebra, then you're looking at something called a basivertebral vein, and that's not something to worry about. And you can see a bit of a remnant of one there. Sometimes you get really big fat ones. Sometimes and you see them in multiple areas. Look, another one there and another one. There'll be more, I'm sure. Look, another one there, like little lightning strikes going down this way as well. And they all seem to stick right down the middle of the vertebra, which tells you that this is definitely a nutrient canal. Great. Let's have a look. Do I have any more? No, I think that's it. Okay, so I think we have finished all the cases. Were there any questions that we have from this? There was just something I wanted to check while we're here. No, there, that looks good as well. Good. So yeah, thank you so much to everyone that's come. I always really, really appreciate it. Keep hitting me up with, oh, someone's raised their hand. Let's look. Sometimes people do that by accident. So if you do have a question, then please feel free. Or if there's sometimes I think we can enable you to talk. So someone to say something? Yeah, you're welcome. I really appreciate that one, genuinely. And oh, I always say this at the end. Do give us feedback. Do let us know. As you probably know by now, I really enjoy teaching, and I'm really glad that Collective Minds enabled me to do this and give you guys give me time and enable me to give you time. And I hope that I kind of you are giving me your time, so I do want to make it as useful as possible. So do let us know. Yeah, my daughter is doing really, really well. Thank you so much for asking. I really appreciate it. Yeah, I mean, people kept telling me at the time that kids bounce back, and yeah, all your prayers and positive thoughts. I can't thank everyone enough, and thank you so much for asking. She's doing great, really, really well, really, really well. Okay, so yeah, it sounds like everyone's good. No big questions. So I guess I'll see you on the next one. I hope everyone has a good month, and yeah, share around, make sure more people come. It'd be great. It's good to spread some positivity. All right then, bye.
Run, and I will be just sending the survey into the chat now. So please do fill that in, and we can send you your CPD certificates out as soon as possible. And please do drop any suggestions of what you'd like to see in the upcoming webinars and just your general experience of the webinar today. And any other information you want regarding the platform, please do feel free to reach out to us as well. So I'll leave that survey there for a few minutes before I end the call.